So paired phaco incisions to treat astigmatism. And I have no relevant disclosures regarding this topic. The pros are it's really easy. You already know how to do it. You have the instruments on your tray, very low cost, fast and efficient. The cons are it's only about a diopter of a cylinder. There are 2 potential leak sites. There are 2 incisions. And there can be a variable response like with any incisional approach. Incision width, tunnel length, corneal position, patient age, all these will affect it. It's not new. There's a 20-year history of paired phaco incisions, but those are much larger, 3.2, 3.5 millimeter. So I said, let's just update it for modern times. We know that making a superior incision is going to have more astigmatic effect than an identical temporal one. So we have to take that into account and not treat them equally. So routine case, I'm going to make my normal phaco incision a little on the short side because I want more astigmatic effect. At the end of the case, eye will in the bag, eye still full of viscoelastic. In fact, we'll put a little more viscoelastic. We'll come back later, remove the viscoelastic, and polish the anterior lens caps with the IA probe. But before doing that, with the eye full of OVD, now let's make the opposite incision. I switch hands for this, but you can certainly use the same hand. And that's the normal technique, just as an incision. That's all it takes. Against the rule, we operate temporally. One phaco incision will cause somewhere around a quarter, maybe a half diopter of corneal flattening. And then more effect with wider incisions or shorter tunnel lengths. A paired incision is going to cause more, about a half to 1 diopter of flattening at that meridian. And then if we do things from superior, so if you look now, I'm actually sitting at the patient's head at 12 o'clock, and that incision is on the steep axis, which in this case is about 90 degrees. So again, filling the eye with more viscoelastic, easy to do with the eye full of OVD. Now make the opposite full thickness incision. It looks like somewhere around the 100-degree mark or so. And so there it goes. And you don't have to go full width of this blade if you don't want to. You can have a little bit less if you want less effect, or go in all the way. And this is a 2.75 or 2.8. So with the rule, you get about a half to 0.75 of flattening with a typical phaco incision of 2.8. Smaller incisions will have less. And if I pair that, I'm getting more, 0.75 or sometimes even double that. So more effect, again, with different size incisions, tunnel length, patient age, etc. You can also sit temporally and then operate on the with the rule 90-degree axis. So here I'm operating at 75. I'm sitting temporal. You can just adjust your stool or your microscope and then adjust your hand position. And there's the incision at 75 degrees, complete the phaco, eye still full of viscoelastic, and here's an opposite incision at that same 75-degree meridian. And again, we don't have to go all the way in if we don't want to. We can kind of titrate a little bit less. And then we're done. Now just finish the case as usual. These incisions seal really well because you've never used them. You haven't been putting instruments and phaco probes and injectors in there, so they seal incredibly well. Diamond keratomes are, of course, my favorite. Those work very well for these. So same concept, beginning of the case, normal incision here, and then at the end of the case, eye full of OVD. Remember that part. We're going to go ahead and make the opposite one here. So here's the data we found. It's a very small study, and I can sort of continue this for longer. But if you look on the left there, that's the against-the-rule patients, our most common ones. And we saw about 0.7 diopters of flattening with full thickness paired incisions of 2.8. So if you're doing 2.2 or 2.4, it's going to be less. On the right side, those are patients who had with the rule astigmatism, and we saw a reduction here of the astigmatism about 0.9 diopters. This is looking, of course, at measure. This is the anterior cornea. We actually have data for the total cornea, posterior cornea, refractive, and we can get into that too. So I'll show you those as well. And I found this to be very useful. I had a patient recently where I ordered a trifocal lens with a toric power, and the rep, special order because it's a high myope, the rep comes with the wrong lens. I'll tell you about that. So wider incision, 2.8 is going to have more effect than 2.2. So the wider incision, the more the effect. If you have a more central incision, which I don't like, I like them at the limbal vessels, central incisions will have more effect. I like them to be far away from the visual axis at the limbus. They're more forgiving. And a shorter tunnel length is going to have more effect as well. And so you keep all these things in mind. But like any incisional approach, there's some variability. And we've said it here by many panelists, if it's a diopter or more, you're probably best off using a toric lens. And that is certainly the most accurate in my hands. And then I've got a very interesting case here. Here we're doing, again, the same type of technique, making the regular phaco incision, and then at the end of the case, the opposite one. And again, you can titrate this by not going all the way inside. You can just stop a little bit short if you'd like to, or for the full effect, go all the way in. This is super low cost. Here's the patient where I didn't get the toric lens I wanted, unfortunately, and I had to do the surgery. She's out of town. Before, you can see on the top left, 1 1/4 of corneal anterior cylinder, and on the right, a quarter diopter. And that's just post-op day 1 with paired full-thickness incisions, and you can see the refraction on the bottom, pretty darn close to what we want. So bottom line is my Nomogram for paired 2.8 phaco incisions. For against the rule, I'm getting on average about 0.7 diopters of flattening. And for with the rule patients, I'm getting about a diopter's worth. And do keep in mind that there is a variability, some more effect if the tunneling's shorter, the incisions are more central, the incisions are wider, and of course, advanced age has more of an effect. And with that, we're done.
Terrific. Thank you very much, Uday.